Good morning. I'm Dr. Isidore Sieleunou from Cameroon. I'm part of this emerging voice venture. I would like this morning to discuss with you on the lessons from the user fees exemption program for the poorest in Benin. In many developing countries, programs to improve the health of the population often fail to reach the poorest. Healthcare fee exemptions can be a financial mechanism to facilitate their access to health services. In order to improve access to health services and move toward universal health coverage, the Benin government implemented in the year 2000 a health equity fund for the poorest. The aim of our study was to review this scheme and draw lessons to improve the system. This is typically what Benin looks like. It is a West African country with a population of about 9 million. Its economy depends on subsistence agriculture, cotton production, and regional trade. Growth in real output has averaged around 5% in the past 7 years. There is a growing informal sector over the year, and almost 40% of the population lives below the poverty line. We use a mixed method approach to perform our study. Quantitative data from January 1st, 2006 to December 31st, 2010 on service utilization and health expenditure, and socioeconomic data from 2006 demographic health survey were collected. We also collected qualitative data to inform the interpretation of the quantitative analysis through in-depth interviews with various stakeholders at all levels of the health pyramid with a semi-structured questionnaire. We did thematic analysis of qualitative data with a framework of core access dimensions: availability, affordability, and acceptability. Our findings: under the healthcare fees exemption program for the poorest, the good news is that service utilization increased among all the quintiles. The less good news is that inequity remains. In fact, for the poorest, utilization increased from 20% in 2006 to almost 29% in 2010, and for the less poor, these rates increased more rapidly from 35% to 57%. The analysis also shows surprising but significant correlations between the level of funding allocation for each territorial department and the number of households classified as poor. The more the poor in a department, the lower the allocation of funds is. Since the funds model is a reimbursement scheme for the service delivery, we then look the average cost to treat the poorest per region. We surprisingly found no correlation between the number of the poor treated and the budget per region. The cost to treat the poorest was highly variable from one department to another and even within the same department. Our qualitative research reports many procedural obstacles, inefficacy of the identification committee, lack of the logistical means for the social worker, use of the fund for other purposes, very long reimbursement delay, frontline health worker workload, as well as demotivating frontline staff. To discuss our finding, we went through a literature review. Castro et al. In 2000 reported that curative health spending in Africa is not well targeted to the poorest. Typically, the share of the subsidy to the poorest quintile is significantly less than that to the richest 20%. Recently, A publication by Mills and al. Show that the overall distribution of benefits is in all three countries included in the study favor richer people, although the burden of illness was greater for lower income groups. In our opinion, the tricky old questions are still topical. The first one is indeed, who are the worst off? A recent study done by Kajijatu and Reed found that even in a household classified as high income, there are some people who might not necessarily have access to the household resources to timely access healthcare. Poverty is also a context notion and has to be accommodated on the local perceptions to include social dimension according to the authors. The second question is how to select the worst of. Some strategies like the community verification is very promising, but remain complex to scale up countrywide. There is also a huge debate between the pre-identification and the post-identification. Above these questions, there is indeed a technical matter of the sensitivity and the specificity of the strategy to use in order to minimize the false poorest selected and the true poorest left out. To conclude our study, we stress that this review presents a very encouraging picture for the funds. The funds actually help the poor to access healthcare they need when they were sick. The main strength of the scheme is that it relies on the national budget, which is a safe source and a sustainable funding. However, the scheme presents also a lot of weakness that we discuss in the presentation. The model needs indeed to be redesigned and should be coupled to other interventions, both supply and demand side. Thank you very much for your kind attention. 7:35